Thank you. Good afternoon, and welcome to the second nurse webinar, Nursing Solutions, Innovations in Parkinson's Disease Nurse Education. These series showcase the work of our nurse scholars who completed the Edmund J. Safra Visiting Nurse Faculty Program at the Parkinson's Disease Foundation. Today's webinar features two scholars, Margaret McCormick and Hannah Murphy-Buck. I will be introducing them very shortly. A little housekeeping before we begin. The PowerPoint slide deck can be downloaded from the reminder email you received this morning or from the PDF web page highlighting this talk. Health professionals can earn one free CEU through the American Society of Aging. Participants will receive an email by the end of the day today with steps on how to collect the CEU. After you register for the CEUs, it may take up to 45 days for them to arrive to you. CEUs are offered for just the first 30 days of this program, that is until November 25th, if you plan on watching the archived version. Next slide, please. Our learning objectives today are several. First, to discuss two methods of student engagement in learning about Parkinson's disease, and we'll use a simulation and a reverse case study as examples. Examine how faculty can facilitate learning using best practices and diverse learning styles in education. Discuss the outcomes of an educational research study about Parkinson's disease comparing teaching strategies, and to share our successes and challenges in teaching nursing students about Parkinson's disease. It's my pleasure to introduce our first speaker, Margaret McCormick, Clinical Associate Professor of Towson University in Maryland. Margaret is a strong advocate for educating nurses about Parkinson's. She completed the Edmund J. Safra Visiting Nurse Faculty Program at the Parkinson's Disease Foundation in 2010 and created the first known Parkinson's disease simulation laboratory. She has performed research on this teaching strategy and published her results. She received the Edmund J. Safra Visiting Nurse Faculty at the Parkinson's Disease Foundation Alumni Award in 2011 for her exceptional work in teaching nursing students about Parkinson's disease. Welcome, Margaret.
Thank you, Gwen. Before starting, I'd like to thank Gwen and the Safra Foundation for offering this webinar and for all the wonderful work that they're doing in promoting leadership and innovation in nursing education about Parkinson's across the country. Many of today's students may not be familiar with the disease trajectory for Parkinson's because their exposure is limited to either an end-of-life hospice experience or maybe when a patient is nonverbal. My goal in developing this sim was to give faculty a vehicle to present information and to help students gain a new perspective and insight into this complicated disease. During this webinar, you will learn about using best practices in teaching, how to engage students with diverse learning styles, and how to analyze learning about the stages of Parkinson's. And finally, I will discuss the outcomes of my educational research with the unfolding case study, which you are all welcome to use and is published in the Journal of Neuroscience Nursing. And you'll see the reference at the end of my presentation. I do believe in lecture, and when done correctly, I think it can cover a lot of content. But what about telling the story of a person living with Parkinson's disease? How do we, as faculty, give students the depth of experience that they need to provide safe and effective care while providing the necessary structure for collaboration in today's healthcare environment? So as you can see, the abstract of my study embraces the use of technology and compares the use of two teaching strategies for undergraduate nursing students. The objective of this research was to determine which method of teaching was best at promoting critical problem solving around common clinical issues related to Parkinson's. The N for my study was 84 students, and they came from 3 different health assessment classes. I received IRB approval from my university prior to the study. Since I wanted to compare teaching strategies, I wanted to make sure that the students got the same information during lecture. So I taped it using a digital media classroom. And if you've never used one before, it's very similar to Panopto. I also included a YouTube video clip to remind them of how to do a neuroassessment. So both groups had pre-sim activities, including an E-medicine article on PD, a taped neuroassessment, and then I posted the 3 commonly used rating scales, the UPDRS, Hohen and Yahr, and the Schwab and England scale, about a week prior to class. Pre-tests and post-tests were given to both groups. However, the post-test was given to the experimental group only after receiving the enriched activity, which was my unfolding case study. As you can see, the simulation framework that I used was described in the Nursing Education Perspective journal in 2005 by Pam Jeffries. It included 5 major areas of concentration. Teacher, which of course is essential to the success of any learning experience, plays the role of facilitator. So they provide the support and encouragement to the learner. But they must remember not to correct mistakes during the procedure or using cues during sim. They are again responsible for guiding the debriefing at the conclusion of the sim. The students, on the other hand, need to know the ground rules. Those ground rules are that mistakes happen during the process. This is going to allow them to be self-directed and motivated while minimizing competition. Faculty can tape this experience using SimView technology. Finally, you can see educational practices is part of that circle, and it addresses active learning and engagement. But it's important to maintain an authentic environment. So if you want to produce smells, use an air freshener under the patient's pillow. You can spray the mannequin's face with water to simulate diaphoresis. You can either use KY jelly or pudding for drool with a cloth or towel under their chin, have a clock in the room, have a telephone for orders or questions, and then, of course, either do taped or verbal report. Finally, you need equipment that is going to help the student go through the sim, maybe a reflex hammer or cotton balls, stethoscope, urinal, and even have a computer for documentation. And finally, the design characteristics. Remember that the objectives are going to guide your learning. So whether you have low fidelity or high fidelity, your outcomes are going to be determined based on whether the students or the group has met your objectives. Now, the next thing you need to do is introduce roles and responsibilities. So in order to create an authentic environment, you want to achieve psychological fidelity. Role cards should be color-coded if you have 3 different scenarios. The mannequins, remember, already have facial masking, so that's a pretty easy one. They already have cogwheel rigidity because they're so stiff. And most even low-fidelity mannequins have heart, lung, and bowel sounds. So if you're trying to simulate autonomic dysfunction, you can simulate constipation with abdominal distension, or pneumonia by putting pudding in a nemesis basin. You can program the mannequin for rales or shortness of breath. And of course, you can create urinary incontinence with a soiled sheet. If the mannequins cannot do what you want them to do, I usually have the student who plays the role of the family member say what's on their mind, or hold the hand of the mannequin to create the tremors and then describe what they observe at home. For example, if the patient is having REM sleep disturbance, the family member can describe it. Finally, you need to have stickers to identify roles as students so the other students know who's speaking, and then make sure that they have a little bit of time so that they can review the paperwork prior to starting the sim. So since this was an unfolding case study, I had a newly diagnosed a patient who is in the middle stage and finally at the advanced stage. So in the newly diagnosed scenario, Mr. Cobbs is a 60-year-old male who shows up at the movement disorder clinic to be examined. He grew up in the Midwest and now lives with his wife in Baltimore. So each scenario can be run independently or hinged on the one before. For my study, all three scenarios were run simultaneously, and then a hot wash was done with grand rounds, where the students shared information about their individual scenarios. For each group, they had one spokesperson, and they were responsible to highlight the important points in the scenario. For example, in scenario 1, the first 5 minutes, the patient had a very low voice and was complaining of abdominal cramping. The expected action would to have the student inquire about normal bowel routine, offer a bedpan, and then a little bit later it gets into the time when they try to raise the head of the bed and the blood pressure drops. So really what I'm trying to get at during this scenario is to have the students recognize postural hypotension. In scenario 2, you now have a patient who has had the disease for 10 years and has been taking Cinemet with good results. It would be important for students to understand the clinical fluctuations and worsening symptoms, maybe due to a skin or tooth infection, dehydration, urinary tract infection, or fever. So you're hoping that they explore the triggers or maybe discuss things about medication timing. Also, fall risk alerts and on-off phenomena would be an important topic to make sure that is covered during this scenario. In the advanced stage of PD, the patient now is 80 years old. He's incontinent of urine, has had the disease for 20 years, and now is having trouble swallowing. Speech is soft, and patient is apathetic. So, of course, they're at risk for aspiration pneumonia, and you would want the students to listen to their lungs to see if there was anything found in the right middle lobe, maybe call the healthcare provider for a chest x-ray, talk to the family about advanced directives, and then actually give them support if there were caregiver strains, make referrals, case manager, and documentation. So it's important to have a computer at the bedside so the students can chart when they have a significant finding. Some of the students' comments about the unfolding case simulation was that now I understand how the disease progresses, and you can see the different pictures. I have a new perspective on the strength of the human spirit. It's opened my eyes about what it's like to live with PD. This will make me a better nurse. So when I debrief, I use the 5 R's. If you're not familiar with it, I think it really helps because debriefing should be done in a quiet room, away from the sim experience. Students come together and discuss and process the information, as well as maybe watch a video playback for self-assessment. The person who is the observer can look to see, did they enter the room after they knocked? Did they wash their hands before providing care? Did they explain what they were doing? Did they show respect to the family and answer their concerns? Decompression is where cognitive process really leads to long-term learning and where application can occur. And of course, there is a lot of tension in the room, so release of emotion is important. And so that's why I go around the room and ask one word to describe your experience during the sim. And sometimes they say they're apprehensive, sometimes they say they were excited or confused, but it's good to kind of get that emotional piece out right away. And then the second is reflection. Tell me about what happened. Describe the big picture. So you can see the picture in the upper right-hand column where students are actually on the board writing a little concept map about how things connected. And then number 3 is the spirit of inquiry. Rather than criticize what they did or what they left out, ask them about what were you thinking when you did this, or why did you do this? Can you help me understand at the time what was going on? The fourth one is the handoff report. So how would you apply it to a clinical situation? So sim debriefing usually is a safe space, hopefully. where you can discuss mistakes or gaps without criticism. Remember, this is a collaborative activity, so I like to give practice pearls. Tell them not to push through a freeze, to avoid clutter, to use a walker with brakes or a seat, to have chairs with an arm. So you're not only teaching them, but we're discussing new ideas. Should there be stock items in the Pyxis machine? How do you avoid medication errors or giving medications like phenothiazides or antiemetics that might cause Parkinson's to get worse? And then finally, do they know the services that are in their hospital? Do they know the referrals that should be made? So the debriefing environment should be one in which they feel challenged, but enough that they're psychologically safe to engage in rigorous reflection. So now I'd like to discuss what happened during the study. So when we looked at the statistics, we found that a within group and between group analysis was performed using ANOVA to compare the effects of student learning using a low-fidelity teaching strategy and comparing it with just traditional lecture. We also did a pair t-test to look for significant difference in scores, so really looking at cognitive improvement. Prior to this, most of the studies were just looking at satisfaction, and certainly the students were much more satisfied with active learning, but I wanted to know, did they really learn something? So when we looked at this, the results of the study, we found that there was a significant increase in post-test scores, and the scores of those who received the simulation were significantly higher. So I'm a visual person, so I'd like to just show you a graph that we did, and you can see that the traditional student went from a pre-score of 4.37 and moved up to 4.93, which was a nice rise in knowledge. But the group that did the lecture and the simulation, which was an enriched activity, went from a baseline of 4.69 and actually skyrocketed up to 6.22 in knowledge. Now, this was really significant because we used 10 multiple choice questions. They were alternative style NCLEX questions, so we used questions that were high levels of Bloom taxonomy, application, planning, evaluation. I included chart exhibit questions and images, and we clearly see that there was a significant difference in knowledge acquisition in the group that had the enriched program. So, in summary, I'd like to say that confidence is built by breaking down big concepts into smaller ideas. Making tasks more manageable for students allows them to have successful that is meaningful about things that they've accomplished. So during debriefing, immediate feedback is a confidence builder, but it also shows the students that they've gained knowledge and an understanding about the disease process. It encourages them that they're on the right track with their thinking and that they have some control over their learning. Success is a direct result of the amount of effort that they put forth. So I would like to acknowledge my co-authors of the study, Jojo Romero de Slavi, who is not only my graduate student, but she was the 2012 Visiting Nurse Faculty Saffir Scholar, and Bonnie Fuller, who compiled the data and ran the statistics for the study. So I'd like you to know that the appendix with the description of all 3 unfolding case studies, including the report to the students, the patient data that you need, the learning objectives, the time frame for the expected outcomes and actions, are all part of the article for you to use when you're teaching your students about Parkinson's. I want to thank you for allowing me to share this with you, and I hope that you enjoy teaching students about Parkinson's using simulation. Thank you.
Thank you very much, Margaret, for that very exciting talk on using technology and simulation laboratories, and for the wonderful resource that we have in your article for more details and for more or less a guide on how to really duplicate this work in other universities. Thank you so much. We'll have questions from Margaret after we hear from our second speaker. And it is my pleasure to introduce Hannah Murphy-Buck. And Hannah is with us today. She is an assistant professor at Notre Dame University of Maryland. She participated in the Edmund J. Safra Visiting Nurse Faculty Program at the Parkinson's Disease Foundation in 2014, and thereafter created a most interesting reverse case study on Parkinson's disease. This flipped classroom model is one I'm looking forward to learning more about today. Hannah was recognized for her work in teaching nursing students by the Maryland Higher Education Commission on Education in 2014. We're pleased that Hannah is here today to share her work with us. Welcome, Hannah.
Thank you so much, Gwen. And I would like to echo Margaret's thanks to you and to the Safra Foundation for all that you do programmatically and just in supporting us one-on-one to bring this content to our students, which in turn, of course, affects the care of patients living with Parkinson's throughout our country and I'm sure across the world. So thank you for all that you do with that. In terms of the reverse case study, I wanted to start my presentation by talking a little bit about the curriculum that we have here at Notre Dame of Maryland. We use Gene Watson's caring science theory as the basis for our curriculum. And I think that's really important in terms of understanding kind of what happens in our classrooms here. Caring science, which is not widely used as a curricular theory, calls nurses to explore questions of meaning and being in all aspects of the discipline and to dwell in the intersection of art, science, and spirituality. Caring science sets forth nursing as a living caring in the world, offering possibilities for growth, healing, and transformation. More specifically, caring science makes it necessary to include, but move beyond, the technical ways of doing and knowing to a way of being with our patients. That combined with the fact that we are a concept-based curriculum means that there are some really creative things that happen in our classrooms throughout the nursing program. I, for one, am a big believer in the flipped classroom, and the reverse case study that I want to present to you is one of the strategies that I use in flipping the classroom. And just a little bit more about what the flipped classroom means. It's a strategy where we're flipping the traditional view of doing homework outside of the classroom and doing lecture in the classroom. And so what we do is we prepare a number of learning activities, whether that be a recorded lecture, a variety of videos, a combination of the two, and then required reading, of course. And students do all of that preparation prior to coming to class. And then we're able to use the time in class to do active learning exercises. What this does, and the reason that I think this is such a great strategy for nursing education in particular, is that it really allows us to do on-the-ground continuous assessment of our students and their ability to critically think through complex patient scenarios and issues. And so in the sharing of Parkinson's disease content, I combine then all three of these aspects, the caring science, the concepts and exemplars used in a concept-based curriculum, and then the flipped classroom. And what I do is I have a recorded lecture that walks the students through the concept of neural regulation and talks about the nursing care that we provide for patients who experience abnormalities in neural regulation. This concept then can be applied to a variety of exemplars, and Parkinson's is one of the exemplars for the neural regulation concept. And so what I have students do is, after they listen to the recorded lecture, they watch a variety of videos that help them to see and understand the types of symptoms that patients with Parkinson's might be experiencing. And then they begin to build what I call a fact sheet. And they put together information about the stages of Parkinson's and define various symptoms, make sure that they look up and understand exactly what dysphagia means, and that they can be able to assess cogwheel rigidity, those sorts of things. So they put all of this together onto a fact sheet, and I give them a list of websites and other resources that I recommend, and they bring that to class. And then we get into the actual learning how to think like a nurse by using this reverse case study. What I want to say here before I get into the case study itself is that another challenge in working with undergraduate nurses is that so often we'll have the experience in clinical or even in a lecture course where students really are quite astonished by how a nurse can walk onto a unit, get report, and be able to immediately plan care for a patient. And as those of us who have been nurses for a while know, that's something that comes with just so much practice, but it's our responsibility as faculty to design assignments and learning activities that help students to move through that learning process and the application into the nursing process as quickly as possible. The reverse case study has really helped me to be able to help students with that process. So for part one of the reverse case study, what I have students do, as I said, is prepare with the variety of resources that I've described, and then bring in their fact sheet. The students are allowed to work together in developing this fact sheet, or they can do it on their own. So once they come to class, I ask them to really begin to engage the story. And what I mean by that is particularly in caring science, reflecting on the patient experience and figuring out how to connect with that experience from an empathetic standpoint is one of the things that we really stress in our curriculum. So what I have the students do is they get into small groups in the classroom, and they're divided by the 5 stages. And each student takes a stage, and I also have just a very extremely brief sort of unfolding case study where I give them the patient's name, the age, and just a very little bit about the patient in each stage of the disease. They then work together in groups to begin to sort of flesh out the information that I've given them. So as the disease progresses and they share that after they've done this first piece of the engagement, the students then have created a story within the full course, the full class, where they're able to tell this patient's story because they've done the pre-work to understand the progression of the disease. I'm able to circulate in the class while they're all doing this active learning to make sure that students in stage 2 are catching on to all of the things that might be different from stage 1. And so when they're then doing their presentation of their piece of the narrative, I'm ensuring that all of the important aspects are being touched on. Then when we get to part 3, we are really bringing alive the nursing process. And I ask students to stay in the groups working on the stage that they have previously worked on and really start to kind of put the rubber to the road in terms of connecting the patient characteristics and experience to the nursing care that they need, and thinking about nursing interventions, pharmacologic management, non-pharmacologic care, and particularly kind of what the roles of the interprofessional team are, and of course always seeking to maximize the patient's quality of life. This is just another visual for the process here. And what I want to bring your attention to is this final stage, mapping the concept. So in the flipped classroom, another strategy that's often used is concept mapping. And what we do there is to visually represent what's going on with the patient. So we can do this on the whiteboard, or we can have students working on poster board in their small groups. There's a variety of ways to do it, but you have the patient information sort of at the center of the board, and then you list out a description of the pathophysiologic processes, a list of expected medications, expected labs, expected assessments, and then you can also link in interprofessional collaboration. And then you plan the nursing care, but you're able to visually connect the assessments, the labs, the pathopharm, and all to each of the nursing interventions, so that the students can see that that all of that is really connected and can see the concept of neural regulation sort of come to life. So, so you can see here that I'm giving a sort of a certain number of minutes, 45 minutes for the original, the first part of the assignment, where students are building the narrative based on the 5 stages. They present that. That's included within those first 45 minutes. The second 30-minute block then is for care planning and really thinking about all of the different aspects of patient care. And then that fourth phase is another 35 minutes or so where the students put together the concept map. Then the last portion of the class, which is included in that 35 minutes, so probably 15 or so minutes at the very end, we look at all of the concept maps and are able to identify the priorities in nursing care at each phase of progression of the disease. Here's another way to look at it and think about it, and this really kind of follows along with Bloom's taxonomy, where we start with knowledge acquisition in the pre-class assignments in terms of reading, listening to the lecture, and building the fact sheet. The fact sheet then, of course, informs all of the work that they do in the class during the application stage. As the students come in and begin building the narrative, they engage in analysis. And then as they begin to plan the nursing process, they're synthesizing their analysis. And then creating the story and building that concept map really gets into creation-level Bloom's taxonomy learning techniques. I want to bring it back to learning to think like a nurse. This reverse case study is actually published in an article in Educational Innovations and is by an author named Beyer. She's from Miami University. And this article, which you'll see in my references, is just walks through exactly how to do this in-class assignment. But what's really great here is that in terms of thinking like a nurse, this case study allows us to sort of back into the nursing process. So by creating a story for a patient, the students really get to take their textbook knowledge and bring it to life. And I think that just really helps the students to understand how to think through the nursing process in a creative way. Students really like this in-class assignment and feel that it gives them the opportunity to be really creative, which students, of course, love to do. Comments on evaluations have included that the assignment was very engaging. I can better understand how textbook symptoms affect the daily life of patients, and it helped me to understand the importance of really doing the homework, coming to class prepared, of course, to best understand not just the pathophysiologic process, but also the patient experience. I've used this assignment a couple of times, and though I have not done a study of its effectiveness, I have been really impressed with how well students have done in terms of, test items on this content and really being able to understand and plan care for Parkinson's patients. In terms of where I want to go next, I have been working on bringing in a clinical opportunity to give students clinical hours for attending a support group, so that they have the opportunity to meet patients and caregivers of patients dealing with Parkinson's, and get to do that in a non-clinical setting. One of the things that I think is so important in terms of sort of the humanization of patient care is having students meet patients who are dealing with very serious disease processes in the community, so that they can learn about how one lives with a chronic disease like Parkinson's. So I'm hoping to incorporate that in the next year or so, and I've also been working on compiling a more significant list of videos to very visually, of course, show the variety of symptoms that Parkinson's patients deal with. So I'm hoping to incorporate those two things and continue with this assignment. These are my references, and I'd really encourage you to check out the reverse case study to Think Like a Nurse article by Ms. Beyer, and that's it for me.
Wonderful, Hannah. Thank you so much. Margaret and Hannah both, I believe, gave us tons of wonderful information and very creative ways of working with nursing students. We are going to open the program now for questions and answers. Please note that questions can be submitted by clicking in the text messaging box in the bottom left corner to type the question, and then hit the send button. We'll be glad to take questions from the audience at this time. And I'd like to start by asking Margaret a question. Margaret, in the simulation, I noticed that you had the role of observer for students, as well as the role of a patient and caregiver and nurse. How do you really optimize learning for the student in the observer's role, and how do you keep them engaged in the process?
Actually, Gwen, that's a really interesting question, because the observer is the least active of all the roles. And if you read the research on it, it's the one that they don't like very much. So in order to engage them in the collaborative process, I think it's important to direct their attention by maybe giving them a tool that they can use to record during the videotaping or the encounter. And then also, once you do the debriefing, make sure that you go around the room to engage them in reflective thinking. So, for example, they may be the ones that notice that there was an unexpected situation that someone didn't pick up during the sim. So it's important to put them in the collaborative process and for them to allow thoughts and feelings to be shared rather than just sitting there passively.
So in essence, I guess they're another set of eyes for the instructor as well in providing some feedback and some constructive thoughts on how things went.
That's true because you're usually running around trying to make sure that everything's going well. So it's nice to have those observers watching things carefully.
Great. Thank you, Margaret.
Mm-hmm.
Anna, I have a question for you. In your model of this reverse case study, students, prepare by reading and watching the pre-recorded lecture and starting the fact sheets. Can you share some tips with us on how to ensure that the students actually do the preparation for this class and come prepared?
Yeah, so with the flipped classroom, that's of course one of the major risks, and kind of gets at the heart of what I was saying about really taking an incredibly active role as the faculty member in terms of moving around to the different groups, making sure people are thinking through things well. But then also in this particular model, I take up the fact sheets at the end of class so that I can just very quickly, it's not a graded assignment, but I can very quickly see whether or not students have prepared. And what I try to do in any class where I'm doing a flipped classroom type of learning environment is I have some sort of pass to class, which is not necessarily a graded assignment, but is some way for me to assess that they've done some pre-work. So I do anything from, asking them to do 3 pages of notes where I can see that they've gone through the different stages of Parkinson's. I'm just using that as an example. But asking students to bring some piece to class that I can take up and just kind of do a quick eyeball assessment. But then also the hands-on moving around and being able to assess students as they're talking in their groups. Now, I will say that Notre Dame of Maryland has a wonderful commitment to small classrooms, and in terms of small class sizes. And so, for example, right now, my biggest class of students is 21 students, and I know that that is not feasible at larger universities. And so in terms of strategies that I know can be used when flipping a classroom when you have more students than you might be able to easily assess over a 2-hour period, a lot of faculty use online quizzing and that sort of thing, so that the path to class is that prior to class you have to take this quiz and score an 80% or higher, and it's just kind of questions that came out of the reading. So those would be a couple of strategies to ensure that students are preparing.
Thank you very much, Anna. Thank you. Margaret, a question for you.
Okay.
I don't know if your university had a simulation laboratory already in process, but I'm curious about the process of setting it up, any cost involved, getting it through your curriculum committee as far as content that you really wanted to make sure occurred. Can you enlighten us a little bit on that?
Well, actually, I ended up creating a seminar course which included the sim. So I really took it upon myself to develop the whole Parkinson's education piece rather than developing the simulation piece. So not only was it a new part of the curriculum, but it was enriching for everyone. So I think what you saw in the study was part of a health assessment class. So the sim, we have developed sim since then and gotten fancy sim view equipment so they could watch themselves. But I think at any university, whether you have money or not, you can easily implement this program.
Thank you. Thank you. Mm-hmm. Hannah, we have a question for you. We have an instructor in the audience who teaches pathophysiology, and first of all, she comments that both of the presentations were just wonderful and very informative. In teaching pathophysiology, she's wondering if a reverse case study would work well in that type of class.
So, bless you for teaching that course. Thank you so much. What I would say is that probably the reverse case study would be better utilized in a clinical course. And the reason that I would say that is that you're really, at that point, applying the nursing process to the care of the patient and the management of their symptoms. Now, I think case study in the context of pathophysiology and pathopharm is really wonderful. But at least in the way that pathophys is taught at my university, we're really not learning the nursing process and the nursing interventions along with the disease process, but it's really more of a sciencey course. So I think, if you're doing a lot of teaching around those nursing interventions, that it probably would be a good option, but otherwise it might be really just better to use this strategy in clinical courses where you're talking more not just about the pathophysiology, but the nursing process as well.
Thank you, Hannah. I can see also, based on what you've just shared with us, that perhaps at a graduate level course, it might work better than an undergraduate course where the students are already nurses and do have some of that nursing clinical decision-making under their belt and are learning some advanced pathophysiology.
Absolutely. Yeah, no, that's an excellent point in terms of using it in the patho course, that at a graduate level that could absolutely be great. We have a educator track in our master's program here, and the pathophys course is focused on not just advanced pathophys, but how to teach advanced pathophys, and I think that would be an excellent application for this type of teaching strategy.
Thank you. Thank you. Margaret, in your research study, we noticed that certainly the experimental group did very well in the end result. I wasn't quite clear about the beginning pretest part. It looked like the experimental group started out a little higher than the control group, and was that significant?
No, I think it, it's just like with any exam you give, depending on the class makeup, you're going to have a different KR. So I think starting out with a different baseline is just reflective of the students that were in that group.
Okay, thank you.
But everyone had pretty much the same activities, the pre-sim activities.
Thank you. Thank you very much. One last question here for Hannah. Hannah, in your design of the reverse case study, is it difficult to get to some of the nuances of differences in Parkinson's disease presentations? For example, we have a saying in the field that if you've met one person with Parkinson's, you've met one person with Parkinson's, because the presentation of patients can be so variable from patient to patient. It sounds like you have a lot of activities and a lot of resources, and I'm just wondering if the heterogeneity, so to say, of Parkinson's disease comes through in the end result.
Mm-hmm. Yeah, that's an excellent question. So that is an issue, and the way that I have dealt with that in the classroom is, as the students are building the case study at the different stages and presenting that information to each other. I often just sort of hit a pause button and talk some about those issues because I certainly want to encourage their creativity and moving through a variety of symptoms, but they're within the context of a 2-hour class. Certainly, we're not going to get to all of that. And I think that it's important to understand that touching on the major pieces around Parkinson's is the most important at the undergraduate nursing level. And so what I'm hoping to do is to clarify their thinking without squelching their creativity, and also to be careful not to overwhelm with detail, but to spark curiosity. Because I think that, and this really goes back to the caring science basis of our curriculum, but I think that one of the things that we have to be so vigilant about in educating our young nurses is to have them understand that in a 2-year nursing program or even a 3-year nursing program, there is no possible way that they can know everything that they need to know about every kind of patient they're ever going to come into contact with. But picking those, and we talk about this in terms of simulation a lot, picking those low occurrence, high impact moments and diagnoses to really key in on and talk about. And so that's why it's really important to me to include Parkinson's, is because while certainly Parkinson's is becoming significantly more common, it's still a disease process that many students are going to graduate from nursing school and have never cared for a Parkinson's patient. And so to be able to key in on many of those differences is really key to the development of a full and holistic curriculum.
Very well said, and I think that circles back to thinking like a nurse. You have to know the basics before you can expand further to variability, and thinking like a nurse takes practice. Thank you both, Hannah and Margaret, for your excellent presentations. We did have one last question here, and I'm just going to mention it, but we're not going to answer it today, and that is of care transitions, patients transitioning from one setting to the next. And we actually have a scholar who right now is writing an article on that very topic, so perhaps we can address that at another time. But for today, our time is just about done. I'd like to refer you to the survey slide and ask that you all please do fill out the survey so that we can better meet your needs in future programming. And also, if you haven't already, don't forget your continuing education credits that are available. You must sort of register for those, and then you will receive them, although it might take up to 45 days to actually receive them back. So thank you on behalf of the Edmund J. Saffer Visiting Nurse Faculty Program at the Parkinson's Disease Foundation. Thank you, Margaret. Thank you, Hannah, for all the excellent information that we learned today. And thank all of our listeners for their wonderful questions and for their participation. Today's conference is now closed. Thank you.